air in, but they can't get air out. So that's why when they breathe in, typically they can get, their volumes are large, right? They already have a very large volume within their lung, and it's easy to get a lot of that in because they're a very compliant lung, okay? But it's hard to get air out because of the hyperinflation in that obstructive property. So it's very hard for them to get that air out. So they do have that bronchial inflammation. God bless you. So with inflammation comes swelling and secretions, right? So secretions, again, are just white blood cells, some other things, fluid and things like that, and they're just responding to this inflammatory response. So if you have chronic inflammation, you're gonna have secretions and swelling that go with it, okay? And so that can lead to potential mucus plugging. Bronchospasms, so when you do have inflammation, irritation, it can cause those muscles to spasm, right? Especially our asthmatic patients. Airway weakening from loss of elastic support. Who's that? Emphysema. That's where that elasticity of their lung, it just becomes one big bulbous alveoli over time. And lung compliance is increased, and that results in the destruction of lung tissue as well. So we have a elastic property of the lung in general with COPD is typically very low, okay, especially with emphysema. So increased compliance, but our elasticity is decreased. Hey, are you looking for something?
No, I'm just super early for next class.
Oh, okay. So we have a lot of these different, and you guys already knew all of this, right? For the most part, some of this isn't maybe new information. So we're just gonna kind of deep dive into maybe why some of this stuff happens and what's causing that. So umbrella, remember, is CBAVE. Included in CBAVE is cystic fibrosis, different from pulmonary fibrosis, very different, okay? Chronic bronchitis, asthma, bronchiectasis, and emphysema. So we're going to cover all of those things, and this is kind of an overview, and then we're going to actually start talking about them specifically, okay? So this is COPD as a whole. Really this whole lecture is. So diagnosis. So how are we diagnosing COPD? So usually COPD is any patient who has a cough with sputum production or dyspnea, or even has a history to exposure of risk factors for the disease. So smoking, maybe they worked at a facility that had a lot of dust, things like that can cause a chronic inflammatory response, okay? Typically diagnosis does require us to do spirometry, specifically a PFT, not maybe our basic spirometry, but an actual full-blown pulmonary function test, okay? So we're looking for that FEV1. So remember, what does that stand for?
Forced expiratory.
Okay, yeah, I'm like, you are right about the forced expiratory volume at 1 second. So we've been exhaling for 1 second, okay? And then we have our forced vital capacity. So we're gonna take, remember you guys were doing the math, I think, where you took that and the FEV1 and divided by the FVC, and you got a percentage, okay? So if that percentage is less than, well, this is 70, so
Yeah.
if it's 70% or less, right? Because if it's greater than 80, it's good, okay? Less than 80, not so good. I forget why I changed that.
Maybe MBRC.
Yeah, I mean, it could be that, but I'm trying to think if this, I wish I had my MBRC book, my exam book. And she doesn't have hers in here either. Okay, I'll double check that. I think we changed it to 80.
I think she taught us 80.
Yeah,
I know she did, and I know I do too, but I don't know. Sometimes I feel like we have to update things. So let me put a pin in that. Say 80 for now, just to follow suit with what I have in the others. But if you're looking at FEV1, FVC, and it's less than 80%, it's going to pretty much confirm that we have some kind of an obstructive disorder. Because we're looking at our expiratory flow rate and our forceful flow rate, right, capacity, and we're looking at those, and if they're both decreased.
If the flow is low, you gotta know.
If the flow's low, you gotta know. That sounds like a Dr. Kreger thing.
It is.
So that confirms that you have an obstructive disease process, okay? But that FEV1, FVC is that real crucial number that we're looking at, okay? So, etiology. What causes it? So, I know this is small. I don't know why it's so small. Tobacco smoke, right? That's a big one. Usually, COPD is going to come from our smokers. Also, occupational dusts or chemicals, air pollution in the air. Sometimes it's just conditions that the patient had maybe at adolescence or even at birth that had an unnormal lung growth, so that's caused them to have COPD properties. Genetic predisposition. So alpha-1 antitrypsin, if you have a reduced amount of it, then you are unfortunately born with COPD, and it's just awful. So to be born with that, and you didn't do anything to, cause it, because most of the time it's caused by smoking, it's just awful. So it affects the lung, liver, and sometimes the skin, but it's manufactured in the liver, and it is the one that, its function is to protect the lung from the neutrophil elastase. So that's what comes in, and it will actually break down breakdown of white blood cells, and yes, free to attack and destroy the elastic tissue of the lungs, because it doesn't have that alpha-1 antitrypsin. The elastase is free to attack it. So it just goes in like it would be if you had been smoking for 30 plus years, or maybe less than that, but for years, and now it's doing what that person would have had to actually go in and be years of smoking that would cause it. So it's just kind of awful for these poor people that are born with it, because it's kids. The kids are born with, then they have COPD. So normal levels are 200 to 400. I don't need you guys to memorize that. I just want you to know that if you have a decrease or you're born with alpha-1 antitrypsin, the decreased levels, that can be a cause for COPD. Okay, so make sure you guys are able to regurgitate that on an exam, because I promise it will be. Yes?
Is that something, that you figure out after you have the baby, or is that something you figure out during pregnancy?
It depends on if you get genetic testing or not.
Okay.
So if you get genetic testing, it might be able to show in that, but if you don't, then it's something that typically you'll find later. Yeah. Good question. Okay. Anatomic alterations. So because it is a chronic inflammatory disease process, we're going to have chronic inflammation and swelling of peripheral airways. Again, excessive mucus accumulation from the inflammatory process, which comes with mucus plugging, bronchospasms, elastic recoil of the lung is decreased, right? So what does that mean? The elastic recoil is decreased. Yes, so it's not able to come back down to its original shape, right? So they're always constantly kind of hyperinflated. Air trapping, aka air trapping, leads to chronic hyperinflation of the lungs. We have a decrease in overall gas exchange, and again, we have the increase in compliance. Okay, chronic bronchitis. So now we're kind of talking specifically about chronic bronchitis. We call these our blue bloaters. So this is a condition where we have a chronic productive cough. So you'll find like that smoker's cough is kind of what I want you to think about. They're just chronically coughing all the time, and they're coughing up phlegm and those types of things. So for at least 3 months to a year is to be considered chronic and productive. And for that, and you must have that for 3 months per year for at least 2 consecutive years is what the ATS is saying. So blue bloater is derived from the cyanosis commonly seen in these patients. So they are chronically hypoxic because they are our CO2 retainers, right? If you look here, we have our nice, beautiful, healthy airway. And with our chronic bronchitis, we have that inflammatory response from those chemicals that they're inhaling, or pus, or dust particles they're inhaling, whatever it is that's causing it. And with inflammation and swelling, again, we're going to have that excessive mucus, okay? They usually, patients respond to increased airway obstruction by decreasing ventilation and increasing cardiac output. So changing our VQ ratio, hypoventilation and increased cardiac, it's just kind of telling you. But really what I want you to know is that they have a chronic productive cough that's present for a long period of time. And they're called blue bloaters. And then we have our pink puffers, which is our emphysema patients. So, pink puffer derived from the reddish complexion of our puffy patients. So if you've seen an emphysema patient, I mean, that's what they kind of look. They look emaciated, like they're kind of withering away almost, because they are working so hard and using those accessory muscles. And that's just, they just kind of start to wither away, right? So they look like they're kind of pink though, and that's because they have that destruction of alveolar walls and oh, okay, so sorry, I'm trying to read what it's saying. Due to the elimination of alveolar walls, what kind of VQ mismatch are we gonna have? So do we have, with emphysema, remember, go back to the VQ mismatch days, do we have a shunt or a dead space? Dead space, right? Dead space what? Is it true dead space or dead space effect, right? So we have a dead space effect. So what's happening? If you look here, we have our normal versus our emphysema. So our normal has all of this surface area, right? What happens with our emphysema? That surface area is destroyed. That elastase is free to come in and destroy all of those alveolar walls and also capillaries, okay? I don't know what's happening right there.
They're going into the class now.
What?
She was just staring at me.
Who was?
That lady, or that girl, whatever.
Oh, the girl that came in here on you.
They're probably just waiting on that door to open.
Yeah.
But 3 of them just went in there, so they probably got class.
Okay.
See, there's more students.
Yeah. Okay. So, anywho, who was staring? The teacher?
No, the student. She was just waiting on the classroom to open, but she
okay.
just was
I just want to
standing.
make sure.
They're
Okay.
staring.
Okay. So I was like, because that teacher sometimes can be. She told us that they came over as lecturing one time. She said, "Can you keep it down? We're trying to test in here." And I was like, I'm lecturing and I don't know how to keep it down.
Yeah,
And
literally lecturing.
Well, and I think we were doing a study fund. That makes, so you guys were all talking and I was like, I mean, it wasn't like that
her door
bad.
shut?
Yeah, oh yeah, her door shut, her door
boy.
shut. I was like, I don't know what to do. But anyway, long story short, I don't care. So, emphysema. Emphysema. So we are losing that surface area. When we're talking about the around the alveoli, what is on the outside that's really important to us? Capillaries. So when we're losing capillaries, we're losing perfusion, okay? So are we still getting ventilation? Yeah, we're just a decrease in perfusion. So remember, that's what our dead space effect is. So we have ventilation in excess of perfusion. So that's what's happening here with our emphysema patients, because we have the destruction of those alveolar walls. I'm gonna make a note about, oh, you guys, I even have it crossed out that I need to put 80. Isn't that funny? So it is 80, I just haven't made the change yet. That's what I'm talking about. I write it down and then I don't ever do it. Okay, emphysema. Remember that about emphysema. Okay, so we're gonna talk a little bit about emphysema. I feel like I said emphysema's not on there, but we're definitely talking about it. So I'm assuming that it meant like specifically emphysema. But some of this, I'll let you know for sure how much of this is actually gonna be on your exam. Whatever we cover. I don't know. It's weird. Okay, so emphysema. There are two different types, and then bolus is kind of not necessarily a type, but it kind of is associated with it, right? So panlobular, centralobular, and then we do have some boli or bolus properties as well. So do you remember, we've talked a little bit about this, I think, right? Yay, nay? I think so. So panlobular is the entire A sinus. So A sinus, remember, that's where gas exchange is taking place. So when we're talking about panlobular, it's this picture down here. So all of the alveolar sacs and where gas exchange is taking place is where we're having that emphysema occurring, okay? So that's usually where we have alveoli destroyed and boli are usually present. That is the most common with our A1 antitrypsin deficiency patients, unfortunately. And that's kind of the worst of the two, a little bit. But, so that's the one. I do want you guys to make highlight of that. It is associated with the A1 antitrypsin deficiency, the panlobular. So remember asinus, when we talked about that, that means that we're talking about where our gas exchange is taking place. So specifically respiratory bronchial, alveolar duct, sacs, and alveolars, the alveoli in general. So central lobular, lesions in the center of the lobules, which results in enlargement and destruction of bronchioles. And that's usually seen with our chronic bronchitis. I don't know why it says and. So it's talking more about this area up here, okay, versus so it says alveolar sacs are normal, but up here is where we have a lot of that destruction and boli that are present, more in that central area versus down in that asinus area. So boli can happen in either areas. So remember, those are those bubble-like cavities filled with air, and they typically can rupture or become inflamed. So once you've destroyed so much of that tissue, and in the alveolar sacs in general, they kind of become one big bulbous sac. And if you think about it, if you're destroying the wall, it's going to become very weak. So those are the areas that tend to rupture or become really chronically inflamed. So if you have a boli rupture, you can have like a small pneumothorax in that case. And of course, with that comes increased work of breathing, those types of things. Sometimes they heal on their own. We don't need to do anything with that. Sometimes we have to put chest tubes in and actually fix or help fix and heal that pneumothorax. Okay. Cystic fibrosis, remember, different than pulmonary fibrosis. Please remember that, okay? Anatomic alterations of cystic fibrosis. So this is a disease process, and we'll talk more about it, but is this something that you can acquire? Or are you usually born with this? You're typically born with cystic fibrosis, and they are now screening babies for that. So they're finding it usually as soon as baby's born, so they can start to, provide treatment when needed for baby. So excessive mucus production is usually what is seen, but it's not just in the lungs, and we'll talk about that at a different time, but it does cause a lot of obstruction because of those, of that mucus, and with mucus you have infection and inflammation. So these patients are chronically sick, because remember, when you have thick mucus, especially where cilia are present, are they able to do their job? No. So there's not a whole lot that they can do except for stay hydrated and do a lot of bronchial hygiene or bronchial toilet and get a lot of that out. So partial bronchial obstruction is seen, hyperinflation, and sometimes even total obstruction. But definitely some atelectasis from that plugging, right? If I have a mucus plug, everything distal to it collapses, okay? So a lot of mucus plugging with cystic fibrosis. So, I did talk about it, okay. So this is the cause of this and why this happens. Is we have an abnormal transport of sodium and chloride across the epithelial cells, okay? So that means that it impacts not just the lungs, because not just the lungs have these epithelial cells. So it's the cystic fibrosis transmembrane conductance regulator, the CFTR. So the regulator that's saying, okay, this is our normal channel. Okay, open up, chloride come in, chloride come out, and it moves freely through this regulator. This is normal. When it comes to cystic fibrosis, those channels are usually closed or malfunction in some way. So a lot of that sodium, that chloride is trapped and not able to go out and thin out mucus and help with hydration and things like that. So what happens is it tends to get thick, and it causes a lot of inflammation, infection, and then plugging as well. So this is happening in the lungs, but also the pancreas as well, and also reaching the intestines. So they have a lot of nourishment issues too. So the pancreas has a lot of properties as far as epithelial cells and mucus, but their intestines that are lined with these cells are also not able to absorb a lot of nutrients. So ADEC, which we'll talk about that later, but vitamin A, D, E, and K, they usually need to take supplements for because they're not able to actually absorb them. So that's something that when you have a cystic fibrosis patient come in, they typically have like dietary on board, a nutritionist, and those types of things as well to make sure that they're getting everything they need. So how are we diagnosing someone with cystic fibrosis? Well, the sweat chloride test. So they do, they actually test their skin to see what their sweat chloride test is, and if it's greater than 60 on 2 occasions at least, that would be considered a positive sweat chloride test. You can also get genetic testing, and what they're saying is presence of 2 disease-causing mutations in the CFTR would be considered having cystic fibrosis, and then also an abnormal nasal potential difference. And we'll talk about cystic fibrosis specifically. We have a whole lecture on just that, okay, actually on each of these. So this is kind of a broad overview of all of these. Okay, bronchiectasis. So this is something that is acquired typically. So it's a disorder of the major bronchi and bronchioles, and we have chronic dilation and distortion of one or more of the bronchi. Usually has that extensive inflammatory destruction of the bronchial cartilage, blood vessels, elastic tissue, smooth muscle. And what usually causes this is cystic fibrosis. So if we have a child that has cystic fibrosis, unfortunately they tend to get bronchiectasis as well. So bronchiectasis and cystic fibrosis are actually pretty similar. They have a lot of similar characteristics as far as chronic inflammation, chronic thick secretions, those types of things. The only difference is the dilation and distortion of those bronchi. That is really specific to our bronchiectasis patients, okay? So what it's actually caused from is chronic inflammatory responses. So if you think about it, cystic fibrosis, didn't we say they chronically have infections from that stagnant, thick mucus that's in their airways? That's why they're always getting like antibiotics, they're always getting aggressive bronchial toilet, those types of things, okay? So cystic or bronchiectasis is caused by chronic inflammation, and if they're chronically getting sick and have chronic inflammation, over time they start to get that dilation and distortion, which is indicative of bronchiectasis. So they'll get diagnosed with both. Now, you can get diagnosed with bronchiectasis without CF. So if you're someone that has, maybe as a child, they've grown up and they've just had chronic pneumonia after pneumonia after pneumonia, over time, that chronic inflammatory response will turn into bronchiectasis. So that is something that can happen. And so it just is really, if you have a lot of inflammation within the lungs, especially if like maybe you have a systemic inflammatory disease process that causes inflammation in the lung as well, like Crohn's disease, rheumatoid arthritis can go all over the place, and it's a chronic inflammatory. It can impact the lung as well and systemically. So that can also cause, bronchiectasis. So it's unfortunate. And then they also have to be aggressive with their bronchial toilet and things like that. So the bronchiectasis has its own pathological and structural changes. So again, we have that dilation and distortion of our airway. So when you look at our airway here, we have loss of cilia, we have increased mucus. Down here, it's showing the destruction of that wall where that dilation starts to take place, where we have a nice, thick, muscle-filled wall there. So really very similar to cystic fibrosis, but just that chronic dilation is that big difference. Another huge difference that I want you to highlight is excessive production of foul-smelling sputum that's usually layered, mean it settles in layers. So you might have frothy, you might have green, you might have yellow, and they're layered. And that's very specific to bronchiectasis. I know, right? Yum. Gross. I'm sure you guys already know. Everyone wants to show you their sputum, but you'll notice that this is very indicative of bronchiectasis. So they'll have bronchospasms as well. Of course, hyperinflation from mucus plugging and trapping and that chronic obstructive property. Atelectasis from plugging and consolidation, and even parenchymal fibrosis at times, okay? So they do have some hemoptysis that's secondary to that erosion of those arteries within their alveoli and bronchial walls. So because they are, we're losing that wall destruction, there will be blood tinged or even hemoptysis sometimes with these patients. So not a great situation. So how do we diagnose this? So routine chest x-rays are going to reveal some of those changes as far as the dilation of airways, but also overinflated lungs, maybe volume loss. We can also do a CT that's going to really show a lot of that chest. And then of course spirometry. Spirometry is going to tell us and determine if we have an obstructive or restrictive process or property there. So chest x-ray, CT, and spirometry. COPD classification. So we're gonna start talking a little bit more about our GOLD. So Global Initiative for Chronic Obstructive Lung Disease. So this is kind of, they'll say gold standard for COPD, and this is literally what they're talking about. So this is their definition of COPD. So chronic obstructive pulmonary disease is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is caused by airway and or alveolar abnormalities, usually by significant exposure to noxious particles or gases. And so there's actually a website that you can go to, and they provide recommendations for treatment. So that's kind of what we're going to talk about as far as the next few slides are going to be all about the gold standards. Okay, we have to teach this to you because they do talk about it on the boards, so you guys kind of have a good understanding as to what the standards are for our COPD patients. And there is a cardinal symptom for GOLD. They say a cardinal symptom for COPD is worsening dyspnea. So write that down, worsening dyspnea, cardinal symptom. So that is one of the symptoms that they say is a good sign that someone has COPD. Okay, their dyspnea only gets worse, not getting better. Okay, risk factors according to GOLD. Genetic predisposition. Again, alpha-1 antitrypsin deficiency is the only genetic predisposition. Age and gender. So COPD does increase with age. So those elderly patients were smoking in their 20s and they were fine, they're living their best life, and now it finally caught up to them, right? So just as our bodies age, so do our lungs, and over time, that destruction really starts to take a toll, and unfortunately, it's when they're elderly is when they start to really have the full effects. So, but age and gender, men are always more susceptible. Conditions that affect normal lung growth. And I think we talked a lot about these: exposure to particles, tobacco smoke, occupational dust and chemicals, pollution, indoor and outdoor. So these are all risk factors that can contribute or cause COPD when we're talking about gold standards. Also, socioeconomic status, asthma, bronchial hyperreactivity, chronic bronchitis, infections, and tuberculosis can also be considered risk factors. So this is overwhelming. You don't need to know, you don't have to memorize this, but this is, if you look at it, it kind of tells you combined symptoms and risks, and kind of gives you an idea as to where you're at as far as your COPD goes. So, spirometry that leads to diagnosis, it's going to say if you have mild, moderate, or severe, or very severe. So FEV1 greater than 80% of predicted. They say it's mild. I don't know why they say that. I'm wondering if they're saying like right at 80. I'm not sure, but you can see moderate is 50 to 79 predicted. So if they hit in that range, then they would consider to be having moderate COPD. And then it progressively, as it goes down to very severe. So that is the assessment of mild, moderate, severe. Down here is talking about our exacerbations, okay? So if they've had greater than or equal to 2 or more, or greater than or equal to 1, leading to hospital admissions, and then this would be if they aren't. So this is really just trying to gather symptoms and classification of airflow limitation over here to give the gold grade, and then also the group that would go into them. And then when we take that information, you can put it into, oh, I must have taken that off. You can put it into, it will tell you more of like treatment. Okay, so they have severe, so they're going to be getting Q4 albuterol. They're going to also be getting steroids. They're going to be getting, maybe like a long acting as well. So those types of things. And if it's less severe, they're going to be like, okay, you can take albuterol PRN as needed with just a steroid. So it all varies on the severity and how many symptoms they have or admissions to the hospital they have throughout the year. So gold standards really just kind of take all of that into consideration. Again, you don't need to memorize any of that. It's really just for to kind of get an idea as to how they get all of that information.
That's like when they protocol someone then.
Absolutely, yeah. It's just a protocol essentially, or an algorithm to find out how they should properly care for a patient in treatment.
Yeah,
Increase treatment, decrease treatment, that type of thing. And then this is another guide that you can use. It's a COPD assessment, and it can really just say, okay, how much you cough, how much phlegm, chest tightness, that kind of stuff, to really give you a total overall score and give you an idea as to if you have COPD or more likely to have COPD and maybe need to get further testing. Okay, so we've talked about different types of COPD. We talked about causes, diagnosis. Now we're going to talk about how we treat these patients. So there are some non-pharmacological treatment for these patients. So education. So we've talked about home rehab in the past, but that would be great for these COPD patients if they're stable enough, right? Physical activity and self-management. So just educating them ultimately on all of these, on everything, but also giving them maybe an idea of physical activity is good for you. I know it's hard for you it makes you, it increases your work of breathing, it makes you cough, but this is actually really good for you, and those types of things. Vaccination, of course, they're always saying that vaccination for these, they're more susceptible to these respiratory illnesses. So they always say vaccines of the pneumovax, influenza, and now COVID. All of those COPD patients should be getting these vaccinations. Nutritional support, IR or interventional bronchoscopy, and even surgery. So these, and we'll talk about it more down the road, but there are actual surgeries that can go in, and if there's like a hyperinflated area of the lung that's causing the patient to have all of this air trapping and discomfort, they can go in and put coils. Have you ever seen coils? I'm sure it's down, but they'll coil and it will like bring that and kind of coil in that part of the lung. So if it's just like a one area, segment, lobe, whatever, not necessarily lobe, but a segment, and they will coil it up to where it's no longer, air is no longer going in. Or they'll put a one-way valve in. If there's a lot of air trapping, they'll put in valves. So it won't allow that airway to collapse. And so not a one-way valve, I think I said, but a valve that will stent it open so that there isn't collapsing. So there's like little things that now they can do for COPD patients that helps. And so that would be done in interventional bronchoscopy or surgery sometimes to remove lobes is also an option. So, of course, comorbidities, anything as far as like diabetes, obesity, those types of things are going to make things worse. Monitoring and follow-up, so routine monitoring of their FEV1 and exacerbations, just to really make sure that they're not getting any worse. If they are, we need to maybe increase treatment or change treatment. And then of course, if it's to the point where they can't, nothing's gonna help, we can talk about end of life and palliative care just to make them comfortable. So we do nebulize morphine for our patients. A lot of those at the end of life COPD patients, especially emphysema, they get very air hungry and they just can't catch their breath. They're just suffocating essentially. And so we will give morphine and we'll nebulize morphine to kind of help with that air hunger that we call. So, and then we do have obviously pharmacologic treatment that we provide. So depending on the severity, remember we're talking about COPD Gold, the assessment tool. We can do SABAs, LABAs, inhaled corticosteroids. And you guys know all about that, don't you? COPD and comorbidities. So when you do have a COPD patient, what do we know? What's happening for most of them? Chronic obstruction causing chronic hypoxemia, potentially CO2, right? And chronic retention. So all of that, you know, honestly is going to cause some issues throughout the system, right? So our heart, it's going to put more strain on our heart. So cardiovascular disease definitely comes into play and is seen with our COPD patients. Osteoporosis, anxiety, depression, lung cancer, sometimes abnormal weight loss and nutritional abnormalities. So these can also, they're at higher risk for those things because they have COPD. And again, if you have that inflammatory response, it's not only limited to the lungs, so we can also see it in the blood, okay? And that can cause systemic inflammatory processes. So patients show increased levels of pro-inflammatory cytokines. So they will do they'll do a blood draw and they'll find that the cytokines are increased. So the C-reactive protein, fibrogen 8, and inflammatory cytokines will have elevated levels, saying that there is a systemic inflammatory response within the blood. So that's obviously going to cause issues because the blood's going to all of the vital organs, right? So they could also have an inflammatory response. Okay, so how is this patient going to present themselves? Our physical exam. Vital signs could be normal. If they're having an exacerbation, we know that their heart rate, respiratory rate are going to be high, and hypoxemia might be present, right? Barrel chest is usually seen in our patients that have been experiencing COPD for years. They start to have that hyperinflation. So dyspnea is going to be involved as well. Cor pulmonale, which is right-sided heart failure, right? So right-sided heart failure, why right-sided heart failure?
Because the other side of the heart is working so harshly, it's kind of like worn out. The right side is nothing like working and like trying to compensate or probably of the left side.
Not necessarily. So when you think about it, when you have chronic hypoxemia, what happens within the lungs? We have, what's secondary to that?
Increased heart rate.
Increased heart rate, but maybe polycythemia. It's something causes polycythemia. Chronic hypoxemia causes chronic or polycythemia. But what about vasoconstriction? Pulmonary vasoconstriction. Remember? And that's secondary to that hypoxemia. Okay, so all of our arteries within our lungs, those capillaries are constricted. Okay, so if we have chronic hypoxemia, it causes vasoconstriction within the lungs. So now we have these tiny pulmonary capillaries that are now even more tiny because they are constricted. So the right side of the heart, does it pump into the lungs or is it getting the blood after the lungs? Yeah, it's going into the lungs, right? So it's going to be working very hard to get that blood through those tiny, tiny capillaries that are now causing vasoconstriction because of that hypoxemia. So now it's working even harder. So over time, it starts to get tired, right? And that's when it starts to fail, okay? So we have right-sided heart failure secondary to that hypoxemia, pulmonary vasoconstriction, okay? Digital clubbing, bad, right? That's all caused by hypoxemia, accessory muscle usage, and pursed-lip breathing. So we know all of this. I feel like this isn't anything new. These are pictures, pursed-lip breathing, pedal edema from cor pulmonale, digital clubbing, accessory muscle usage. And this is just from your book. It might be the book before, I can't remember, but it just gives you a bunch of different information. I don't expect you to go through and read all of that or know it, but it is in your book. Okay, diagnosis, procedure, and tests. Test findings. So diagnosis of COPD according to GOLD. Key indicators for considering COPD in patients in ages over 40. Number 1, you see it there, worsening dyspnea or dyspnea. That is gold standard. Worsening dyspnea or dyspnea is going to be one of the key indicators that a patient has COPD. Chronic cough, sputum production, history of exposure to risk factors, and also they found that COPD can be somewhat hereditary if they have a family history of. So usually they have one of the other things going on, like they've been exposed to risk factors and then they also had family history, and those two kind of go hand in hand, but that can also be a risk factor or indicator. Okay, we can also do 3 main spirometry tests, FEC, FEV1, and then we get to that ratio. Everything should be less than 80% to be considered an obstructive disorder. So you can see here we have a normal patient versus up here versus our COPD patient. So we're talking about, this is our seconds, and this is our volumes, our liters, okay? So you can see they have a lot more volume than our average normal person, and look how long it takes them to fully exhale, right? Increased volumes, decreased flows, right? That's our COPD patients. So expiratory flows, FEV1, again, 70, I don't know, I need to change all that, 80 or less. FEC, decrease less than 80. FEV1, decrease less than 80. Volumes are going to be either increased or normal for the most part, but RV, increased or normal. The FRC is typically always increased. TLC can be increased or normal. And then again, our vital capacity will be decreased. And then the DLCO is special. So we can have all of these findings and saying, oh, they have COPD, but our DLCO can come back as being normal. And that will tell us a lot. We know then it's not emphysema, okay? So if we're trying to figure out exactly what kind of COPD our patient has, we can do a DLCO. It will be less than 80 in our emphysema and normal in our chronic bronchitis. Bronchiectasis and CF, we're not usually looking at just this, we're looking at other factors, right? But if we're just using spirometry to figure out what type of COPD, it will rule out emphysema versus chronic bronchitis, okay? Because asthma, we use the methacholine. We're gonna be using chest x-rays, the sweat chloride test, those types of things for the other ones. But this will tell the difference between chronic bronchitis and emphysema. So that I have seen on your boards where they say a DLCO, everything's showing COPD and a DLCO is low, and so then you automatically know it's emphysema. Or it's not, right, if it's not low, so. Are you guys PFT'd out or what? Okay, mild to moderate COPD, our arterial blood gases are going to show they haven't usually quite compensated yet. So their bodies are still kind of compensating. So their pH might still be a little bit on the acidotic side. CO2 could be low depending on if they're in exacerbation or not, okay? And then bicarbonate would be low, PaO2 is gonna be low, and so will their SpO2. So once they have compensated, usually our severe COPD patients have definitely compensated, that pH is then going to be normalized, right? CO2 will be up, bicarb will be up, and of course our oxygen's always going to be down. I don't expect you guys to memorize those. I do expect you guys to understand that if they that our COPD patients have elevated CO2, and that usually it does cause the pH to be normalized. I guess the pH will normalize, high CO2 and high bicarbonate, okay? That is very characteristic of our COPD patients. And if their pH is normal, it's usually like 7.38. It's on that acidotic side. Okay, so with our chronic bronchitis, you will see that they will have air bronchograms, I think that's what they call them. So you can see where there's inflammation and white throughout. It's really highlighting that airway. They call that like an air bronchogram. So they'll have some of those, and it's usually from inflammation. Flattened diaphragm, and they will tend to have a more long and narrow heart. But if you look here, it's kind of hard to see a flattened diaphragm on this one. The next one I think I have a little bit better. So emphysema, you'll see, I don't expect you guys to know, like, oh, you can tell that's COPD, look at that chest. I'm never testing you on that. I'll do some like pleural effusions once in a while, pneumothorax, but nothing like this. So wall of blebs, I mean, I can look at that and say, that looks like atelectasis to me or pneumonia. So I would never expect you guys to know anything. Flattened diaphragm, again, heart long and narrow, but they are going to have more translucency than normal. So when I'm talking about chest x-rays, which we'll get into next week a little bit, translucent is going to be more dark than the white, okay? So white is typically our bone, tissue, secretions, fluid that's in our lungs. But if you have a lot of air, it's gonna be dark, okay? So if I have a lot of air, like my emphysema patients they're just totally hyperinflated, you're gonna see a lot of dark, okay? And a lot of destruction of those vasculature markings. Like some of, you're gonna see white in a lung because there's capillaries, there's blood, okay, that's supposed to be there. But if you're seeing like areas of barely any vasculature markings, you're talking about a pneumothorax, or you're talking about an emphysema patient where there's actually been destruction of those capillaries in that area. Okay? Or underexposure, but whatever. So. And then this is bronchiectasis. So you can see we have a lot of consolidation throughout. It almost looks like ARDS to me. So they've got a lot of secretions in there. This is not normal vasculature markings, okay? We should not see that much white. So you'll still see translucent, some dark fields, depressed, flattened diaphragm, areas of consolidation. Sometimes they'll have an enlarged heart, and maybe some atelectasis here and there. I'll show you more chest x-rays. I'll probably show you chest x-rays every week of something, so you'll start to get more familiar with them. And then cystic fibrosis and bronchiectasis are pretty similar. Okay, how do we manage COPD? Avoid your risk factors. Boom, end of story, right? Yeah, that doesn't always happen, right? You can tell someone they have COPD and they're still gonna go home and smoke, and it's gonna continue to get worse. So, but avoiding the risk factors is something that we can at least educate them on. So smoking cessation, If they know that what their triggers are for asthma or exacerbation in general, just try to avoid it. So if it's pollution, you know, try to stay inside when you know it's high pollen, or, you know, there's been those days where like, everyone stay inside, the pollution, the air is full of smoke from fires from somewhere, or the air quality is really low. Those are the days these patients should probably avoid being outside. Reduction of occupational exposure as well. So if they come to find out, you know, they've been painting, my dad was a painter, and he didn't wear a mask for years, and he painted cars and like a body man, and I mean, you can only imagine the particles that went in his nose. And I'm like, you're definitely, I mean, he smokes too, so it doesn't really help, but he definitely has COPD. So those patients, especially back in the day when there wasn't a lot of precautionary things, they will find that now, definitely, but to stop that as soon as they can, or at least start to wear protection of some sort. And then of course we want to talk about smoking cessation. It's usually the most effective and the most cost effective for these patients when they are smokers. So we should always try to get them to quit, but the patient has to be also on board with that, right? You can talk to them until they're blue in the face. Unless they're ready, they're not going to do it. So, but this does show you, and the crosses do indicate death, I know. This is showing you, I know, it's like death. So it's talking about FEV1 and the age. So it's telling you a progression. So someone that's never smoked, you know, these are the age, their lung function stays pretty good. I mean, it still declines because, again, as we get older, our lungs do age too. Still declines, but they still have pretty good lung function into their elderly years. Someone that starts smoking and then stops will actually see no more decline after they stop. Now, that doesn't mean their lungs are gonna get better, but they're not gonna get any worse. And at that point, that's not a bad deal. So if they do stop, you will see that they have some disability, but it's usually much later in life. But if they continue to smoke, it's just completely, they decline, and they die, pretty early, usually from complications. Even if they stop at 65, look at, they gave themselves a few more years. So stopping has been shown to really increase lung function, or at least stop that decline. So I know the cross is like, oh, it's death. I'm like, yeah, it definitely is. It's death.
Stop or die.
You stop or die. When I saw this as a student, and I was just like, I'm gonna show this to my dad. I'm like totally showing this to him. He don't care, but whatever. So, but if you
He still smokes.
yeah, he had like necrotizing pneumonia one time. He's like, I'm done. I was like, good. You should be done.
Go right back to it.
About a month later, he was like, I couldn't do it. I was like, I can't talk to you right now. So anyway, I guess that's job security right there. But management, we can also help with aerosolized medication. So we are pretty used to some of these. It reduces the patient's symptoms, can help with severity and risk of exacerbation, overall health status and exercise tolerance, all these fun things. So we can either give it prescribed on a regular basis or as needed. Very helpful with a lot of our COPD patients is having that aerosolized medication therapy. We can also provide oxygen, right? Sometimes they will need supplemental O2, and really we're targeting that 88 to 92. We're not wanting them to be at 95 to 100, right? That's not really where they live. So long-term O2 is indicated in the patient with a stable disease who has a PaO2 of 55 or below, or their saturations of less than 88%, even with or without hypercapnia. So they will do tests. This is kind of that overnight oxygen. They'll also do like the 6-minute walk and stuff like that. But long-term O2 can be something that we will provide for these patients, especially emphysema. They will need to have supplemental O2 as it progresses. Airway clearance, so especially for like our cystic fibrosis and bronchiectasis, and even sometimes our chronic bronchitis. But secretions, they will definitely need to do some kind of pulmonary toilet, and that would be postural drainage. You can give them like a the acapella to take at home. Best therapy for CF patients and bronchiectasis, they will do that around the clock. That is something that they get used to. They'll do IPV. Sometimes they alternate at home. Depends on what they're used to and what they what they like. So we will definitely be providing airway clearance therapy. And then of course pulm rehab is beneficial as well. So getting them exercising and moving. I feel like sometimes the more sedentary they are, the more aggressive the disease becomes, and it progresses much faster than if you are exercising. Even exercising helps with some of that mucus clearance, right? Getting up and moving, they'll be coughing, but they're gonna get it out, those types of things, so it can help. And then of course exacerbations. So an acute event, so what is an exacerbation? This is what it is. An acute event with a worsening of the patient's respiratory symptoms that is beyond a normal day-to-day changes and leads to a change in medication. So most common causes appear to be the 3 cardinal symptoms of exacerbation, which you're gonna want to know these. So worsening dyspnea, increase in sputum production or volume, an increase in sputum purulence. What is purulence?
What is my pearl white?
Pus? Yeah. So infection, right? Make sure you guys know those. Management of exacerbation, we can provide bronchodilators. Sometimes they'll even need systemic corticosteroids, not just inhaled. They'll actually have to take an oral. Sometimes we can provide non-invasive positive pressure ventilation, so like face mask, BiPAP, and then also antibiotics if they do have. Usually what's happening is they have COPD and then they get a cold, pneumonia, and it just exacerbates everything, okay? So then it gets to the point where they can't manage it at home anymore and they need to seek help. Additional treatment, we have augment therapy, so also known as replacement therapy for those patients with severe alpha-1 antitrypsin, and we can provide the medications Prolastin, Arelast, Zamaria, Glossia. They can do a lung transplantation. You gotta stop smoking for that, right? Sometimes they won't even talk, or you know what I'm saying, classify. What am I saying? Qualify. Thank you. I'm like, what is the word? And it is a one-way valve. I'm sorry. I thought this is that
The
one-way valve I
IBV
was
valve
talking
procedure
about.
is considered minimally invasive and can be performed through a flexible bronchoscope. Prior to valve placement, a calibrated balloon is used to size the airways targeted for valve placement. The targeted airways are occluded with the IBV valve using a deployment catheter. The IBV valve is self-expanding and conforms to the airway. There are 5 anchors that gently penetrate the surface layer of the airway, preventing migration. Once in place, the IBV valve expands and contracts with breathing, blocking distal airflow while allowing trapped air and fluids to escape.
So that's to help with that
Multiple valves will be
hyperinflation.
needed to occlude all the airways leading to a targeted lobe. Air is redirected away from that lobe to healthier tissue. Complete occlusion of the target lobe may allow atelectasis or reduce volume in the target lobe, which can relieve hyperinflation, enable healthier tissue to expand, and make breathing easier.
Isn't that crazy? It's amazing. Who, like $1 million idea right there. Okay, and then this is that coil placement I was talking about. Oh man, it is old. Let me look for it. Let me just look it up here.
Oh, I didn't put it right.
Yeah.
The JAMA Network.
This patient has severe emphysema.
Emphysema is the lung, which is impaired. It improves
So those are
the
coils.
elasticity of the lung.
The study included 100 patients from 10 centers across France. 50 patients had an average of 10 coils placed in their lungs, and the other 50 received standard medical treatment. Both groups were followed closely and assessed at 6 and 12 months. They participated in a 6-minute walk test to see if their
Just cruising along. All right, I really wanted to see the